thank you so much for joining us for today's public forum, More Than Skin Deep, Understanding the Impact of Autoimmune Skin Diseases on Women's Health. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. SWHR is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. Today, we are so pleased to have three distinguished panelists joining us for this event. We have Dr. Arash Mostagimi, Assistant Professor of Dermatology at the Brigham and Women's Hospital, Kelly Barta, State Advocacy Project Manager for the Allergy and Asthma Network, and Leslie Stein-Lloyd, Director of Public Policy and Healthcare Economics for the American Academy of Dermatology Association. I'd like to thank the sponsor of today's event, Eli Lilly and Company, and we will be live tweeting during the event. We invite you all to join us and use the hashtag SWHRTalksSkin on social media. And so with that, at this time, I'd like to introduce SWHR's Director of Science Programs, Dr. Irene Aninye, who will be moderating today's forum.
Thank you, Katie, and welcome everyone. Autoimmune skin conditions cause a person's immune system to attack the body's own tissues and organs, including the skin. Autoimmune and immune-mediated skin conditions have a complex and chronic health implications for those affected. Because the skin is so visible and important to the body's physiological function, skin diseases can impact a person's physical and mental well-being and carry a large public health burden despite their relative understudy. Atopic dermatitis, a common form of eczema, is characterized by itchy, dry, flaky, and irritated skin and can affect women differently over the lifespan. In the United States, an estimated 16.5 million people are affected with atopic dermatitis. 700,000 people have been diagnosed with alopecia areata, which causes hair loss primarily in small round patches on the scalp, but can also affect eyebrows, eyelashes, and other hair-bearing areas of the body. And up to 30% of approximately 8 million individuals with psoriasis will also develop psoriatic arthritis. This immune-mediated condition has inflammatory effects in the skin, joints, and tendons. These are just three diseases that affect women disproportionately and differently than men due to biological sex differences and influences based on gender, affecting them not only as patients, but also as caregivers and sometimes as both. SWHR's autoimmune skin programs in atopic dermatitis, alopecia areata, and psoriatic arthritis were founded to draw awareness to research gaps and unmet needs in clinical care, education, and policy. This summer, we convened a working group of expert researchers, clinicians, policy professionals, and patient advocates who are passionate about improving care for women with these chronic autoimmune skin conditions. With the guidance of these experts, SWHR has developed educational materials to assist primary care providers recognize and diagnose these autoimmune skin conditions so that their patients can better navigate their care. And today, we have three experts from our working group with us to share outtakes from the closed meeting discussions on the health, social, and economic impacts of autoimmune skin diseases during this public forum, as well as some of their professional and personal insights on the topic. Following the speaker presentations, I'll be moderating a discussion with all of our panelists, so we invite you to use the Q&A box to submit questions throughout the event. We will start with Dr. Arash Mostagimi, who will speak about how autoimmune skin diseases differently impact women and treatment options that are available for emerging and long-term care. Thanks for joining us, Dr. Mostagimi.
Thank you so much for having me, Irene. And I think it's really a pleasure to be here on this panel. And just to give you a brief overview of these specific autoimmune diseases that Irene introduced. Next slide, please. So as Irene mentioned, over 80% of the 23.5 million Americans with autoimmune diseases are women. And of autoimmune diseases, there's many autoimmune diseases that reflect primarily in skin or solely in skin. And then there's also autoimmune diseases which have a skin-related component. We're going to go through three today: alopecia areata, atopic dermatitis, and psoriatic arthritis. Next slide. So alopecia areata is a disease of hair loss. You have an autoimmune phenomenon that has not been fully characterized, in which patches of hair are lost from the body. What happens is that the immune system recognizes the hair as being a foreign substance and comes under the skin where the hair bulb is. This woman in this picture has alopecia areata. These are actually different round patches when put next together, form this large area of hair loss that you can see. In some people, the hair loss is restricted just to one or two areas on the scalp. In other people, it can be reflected all over the body, something called alopecia universalis, with lots of eyebrows and eyelashes. Despite having a lifetime prevalence of between 1 to 2%, with 700,000 patients in the US actively, there are no FDA-approved treatments. The good news is that there are 3 drugs currently in late-stage clinical trials that are being considered, but in reality, the treatment for this disease involves injections of steroids with a needle into the scalp. You can imagine how uncomfortable that is. And we're not just talking one shot, we're talking sometimes 15, 20, 30 shots in a row, and patients come on a monthly basis for that. So that goes to show you first how crude and limited our current treatments are and how motivated our patients are to undergo that therapy to try to regrow their hair. The result, the reason that they're so eager to get the treatment is that the disease has a profound psychosocial impact. It's not a disease that generally hurts or itches, but the idea that you aren't able to express yourself via your hair in the way that you want is problematic, particularly among women, as we'll discuss later. Next slide. Atopic dermatitis is also known as eczema. Not all types of eczema, which is basically an itchy skin rash, are atopic dermatitis. People with atopic dermatitis actually have a problem with a protein in the skin called filaggrin, which contributes to skin integrity and protects from inflammation and infection. It's super common, particularly among younger children and babies, with 16.5 million patients in the United States. When you lack that protein or you don't make it properly, your skin breaks down and you have a tendency to get itchy patches, as we can see in this picture, skin breakdown, and then you get infections on top of that. There's been some progress made with medications, with the introduction of the first systemic agent that was FDA approved for this indication about 6 or 7 years ago. While that's been great to see those strides and other drugs are in development, we still lack a general awareness and access to these medications in a way that's consistent across the population. As a result, people with atopic dermatitis, while in your mind you can think, oh, I've had a little scratch or a little itch here and there, imagine basically having an existence that feels as though you're having itchy, burning poison ivy, but not just for a week or two after gardening, over years and years and years. It leads to itching, it leads to pain, it leads to sleep deprivation, and has long-term impact on people's lives and well-being. Next slide. Psoriatic arthritis is a related condition to psoriasis, which, like atopic dermatitis, is a scaly condition of the skin. In psoriatic arthritis, about 30% of the people with psoriasis can develop painful inflammation at their joints. So if you look in this picture, you can see in this woman in her fingers, she has red swelling, which is restricting the movement of her finger. And then if you were to touch it, she would leap her finger, she would pull her finger back because it's so tender and painful. This is not only a problem when you have the inflammation, you have the condition, but progressive inflammation and repeated bouts of inflammation leads to chronic destruction of the joint, leading to a condition called arthritis mutilans, where you have very limited ability to grasp items or use your hands. Psoriasis can be treated with a variety of medications, but psoriatic arthritis specifically requires systemic medications. And while there are many different therapeutic options here, again, they're not broadly available, and we still have gaps of people who don't respond properly to these treatments. Next slide. So we're here at a conference today to talk about the impact on women. And while we fortunately have made substantial progress in talking about the impact of these diseases in general on a population, it's really important to understand that the epidemiology of these diseases for women is not understood completely and is actually overlooked. There's substantial differences in disease presentation between women and men. And there's variation in impact of environmental exposure. So we don't quite understand over the course of a woman's life where you have differences in hormones before and after puberty, during pregnancy, after menopause. We don't quite understand the interplay of that normal cycle of a woman's life with these conditions. We also don't understand the differences in exposures, the differential work that women do, particularly in the households, where they can be exposed to different solvents, different volatile compounds, et cetera. We don't understand whether or not that impacts these conditions, whether directly like an eczema where you can get skin breakdown, or indirectly in terms of being the initiators of these diseases. We don't really know why some people get these diseases and some people don't. Next, what is equally and maybe even more important is the psychosocial impact of the disease. So aesthetic standards are very different between men and women. If I was to lose large patches of my hair as a male, I could shave my head, and that would be a generally accepted haircut for men. Now, that's not to say that men are not affected by alopecia areata, because they certainly are. But as a woman, if I had alopecia areata and shaved my head or lost all my hair, that viewpoint is immediately associated with psychological distress, cancer, and similar types of, you're expressing yourself in ways that you don't have control over. Where a lot, this has impacts on people's self-esteem, on people's ability and desire to do something like what I'm doing right now, which is talk in front of a group of people. It affects their sexual quality of life and their ability to obtain and maintain relationships. And finally, even for women who are not having these diseases directly, if you have atopic dermatitis in an infant, or you have another member of your household with disabling psoriatic arthritis, the caregiver burden is concentrated among women. So this is something that has a disproportionate impact on women in ways that are not fully and completely understood. Next slide. So the road ahead for us really involves focusing on improving research, understanding exactly the variability of challenges both within and between these disorders and among women across all races and all different points in their lives. While there has been some progress in drug development, we need to focus on drug development, on continuing that. We need to understand whether there's biological differences in response to medication. And finally, the question that many of my young patients, for example, with hair loss ask is this drug safe for me during pregnancy? Is it safe for me during breastfeeding? Will it have impact on these things? These are questions that are not yet understood. Further education to help both lay people identify and understand these treatments, these diseases, so they can understand when they have them and seek medical attention is super important. It's amazing what people will get used to and living with over the years. And also education for providers to understand and acknowledge that these are serious diseases that are impacting people and that need to be treated aggressively. There's often undertreatment or a tendency towards diminishing the complaints, particularly of women of color or socioeconomic means. And finally, that is related to this final issue that even if we understood the disease, had patients show up, had drugs that work, we still don't have equitable access towards medication. There's high cost of medication, the variability of insurance coverages, variability in access to physicians who feel comfortable prescribing these medications. So it's important for us to think about all of these factors and to lay the foundation for understanding these diseases, improving their recognition, treatment, and ultimately outcomes for patients with these conditions. Next slide. I will take questions with everybody else at the end of the presentations. Thank you very much.
Thank you very much, Dr. Mostagimi. I'd like to now invite Kelly Barta to share her own journey with atopic dermatitis and how it is tied into her passion for advocacy work in this space.
Thank you so much. It's a pleasure to be here with all of you and a real honor to share on behalf of patients living with eczema. I am a lifelong atopic dermatitis patient, and I've also gone through topical steroid withdrawal. You can see me here in these pictures on the left. I'm with my two sons who are now 15 and 20, and with my siblings. And for many, many years, I was able to live a very active life with eczema. more or less a normal life. I did a lot to hide any rashes that I had and manage those. Over time with medication, I tried to drown out the itching and the pain and the interrupted sleep that I had to deal with. But within my 30s, I was in the surprise of my life when I had a reaction to a medication that I was using for topical steroids, or for eczema, which is topical steroids, the current first line treatment. And so I just want to go ahead and share with you my story and how I got there and where we do go from here. So I grew up with a very typical case of eczema. I was diagnosed at about 5 years old, and I had the rashes that most people have in the crooks of the arm and the behind the knees. And I managed that with moisturizers and with over-the-counter hydrocortisone cream. But when I was around 12, the rashes began to spread to my neck and my hands, which prompted a visit to the dermatologist, who then prescribed topical steroid to manage my skin. And these medications, they work like a charm. Whenever a bit of rash pops up, I would apply a thin layer of cream, and within several days, my skin would be clear. But as with any chronic condition, as was mentioned with the alopecia areata before as well, steroids cannot cure the disease, they just manage the symptoms. So my rashes would continue to pop up, and I would have to continue to use steroid creams. So when I was in my 20s, I started having capillaries break around my face because I was using them around my mouth. And fortunately at that time, Protopic, another immunosuppressant, came out on the market. And so my dermatologist had me use that on my face and steroids on the rest of my body. And I really managed my skin that way for about 26 years. And although my skin seemed manageable with this treatment, I began to slowly develop a host of really strange allergies. It started in my 20s again when I was working in food service. I had to wear latex gloves every day, and I developed a latex allergy. I then began to notice more food sensitivities, developing to the point where it was difficult to find anything on a menu when I was at a restaurant. I began to have trouble with chemicals like paint and cleaning products. My skin started to break out from clothing detergents and fabric softeners. And even when I would go to stores to try on clothes, I would have breakouts. So I really became concerned when I started to break out in hives when my skin touched surfaces like the seat of my car, or when I would put my hand into my purse, I'd pull it out and I'd have hives. I questioned my doctor on if steroid use could be contributing to my heightened allergic response, and my requests were unfortunately dismissed. And I was told that trying to nail down what was causing my eczema would only drive me crazy, that I had an incurable inherited condition, and I would need to stay on steroids for the rest of my life. Shortly after that office visit, I was at the pharmacy picking up my prescription, and there was a new pharmacist there at Costco, believe it or not. And she asked me how long I had been taking these high potency steroids. And when I told her 26 years, this look of shock just flashed across her face just for a second. But it really disturbed me, and it made me even more determined to dig into how are these medications actually affecting me, and could they really be connected to these strange allergies that I'm experiencing? So I did some studying and some research and found, yes, there is a correlation between long-term steroid use and heightened allergic response. And this particular study talked about using a better barrier cream, as we heard about earlier, to create that barrier so that antigens and irritants don't get into the skin and cause flare-ups. So little did I know, I started using less of the steroids, more barrier creams, but I was weaning myself off a medication that I had become dependent on, and I had no idea that I was in for the surprise of my life. So about 3 months, over that time, I lessened the use of the steroid creams until I was only using it on my hands, which were the worst area for eczema for me. I finally stopped completely, and within 2 days, my skin began to burn terribly. This was accompanied by a bone-deep itching. I ended up staying awake the entire night on the couch in so much pain, I actually had to breathe like I was in childbirth, if you can imagine. So I was trying to think what I had done that could have caused these symptoms, and the only thing I really had changed was stopping completely the use of steroid creams. And I knew that stopping oral steroids cold turkey would cause a rebound. And so I thought to myself, perhaps I'm having some sort of a withdrawal going on. So I Googled, as many of us do, in the middle of the night, and I came across a nonprofit called the International Topical Steroid Awareness Network, ITSAN. And this is a nonprofit organization that provides support for individuals going through this topical steroid withdrawal syndrome. And from the resources in the scientific literature that I found on the site, I finally was able to connect the dots with my worsening skin and the allergies and the long-term use of steroids. I had that aha moment that so many others in the eczema community, especially women, are beginning to have. Topical steroid withdrawal was described as a severe and protracted condition resulting from overexposure to steroids that could last from months to years. But through the cessation of steroids and given time, a person would heal. So as morning came, I went upstairs and sat on the edge of the bed. My husband had told him what I believed was happening, that we were in for a couple of hard months. I figured I would heal faster than those I had read about because I was a very healthy person. I had a very healthy diet. I exercised regularly. But as you can see in these pictures coming up, that 3 months came and went, and I went from bad to worse. The burning in my skin that had started just within several days of stopping became so severe that I couldn't even lift my arms above my head to undress. The tissue under my skin began to swell all over my body, giving me elephant wrinkles, which you'll see in the next picture. My legs became purple upon standing and would ache so badly I couldn't be on my feet for more than 15 minutes at a time. I began losing weight, so much so that I finally stopped getting on the scale. And you can see there that picture on the left. I think I lost probably 30 pounds or even more. I was completely exhausted and my nerves became so raw, I eventually couldn't even be around people anymore. All I wanted was to be in a dark, quiet room. And even though I was exhausted, I couldn't sleep at night. I would lay awake until around 8 in the morning and would only get about an hour or two of sleep. I felt like a burn victim, like someone had poured boiling water over my whole body. I was in so much pain, I had to lay completely still in my bed and plan my trips to the bathroom or even to get food. Sometimes the burning was so bad, I even debated whether or not to reach for the remote to watch TV as I laid in bed. My skin began to break into hundreds of tiny fissures and ooze out a foul-smelling liquid, which made me have to lay naked on towels that were continuously changed. When the ooze dried, I would stick to whatever surface I was lying on, and when I moved to get up, peeling myself off that surface would rip open all of my skin again. All over my body, my skin was shedding profusely, and I had no idea that the body could reproduce skin that fast. So, there we go. So the bath was the only place that I had felt relief. So I began to live between the bed and the bathtub. And I was in this state for over a year and a half, bound to my bed like a prisoner, watching the seasons go by out of my bedroom window. My hair fell out. I developed a cataract and needed a lens implant. I developed these mysterious lumps, like you can see on the left there under my arm, that were very painful and scary. And there was always that unrelenting, horrible itch that would come in acute attacks periodically throughout the day. It was intense, unending suffering 24/7. And all this time, my husband had to take over my responsibilities with our kids. I couldn't be a wife or a mother. I couldn't work a job. I had to completely let go of life as I knew it. This condition impacted my whole family very, very severely. My kids have dealt with depression and anxiety. My 21-year marriage fell apart. So over time, little by little, my body did begin to heal, but it took about 3.5 years. And that's where you see I am here about 3 years in to function even somewhat normally again. So right around the 4-year mark, I had a life-threatening outbreak of eczema herpeticum, a skin virus that's very common to those in our community going through TSW. This is yet another frightening consequence of using topical steroids long-term, as they compromise the immune function in the skin. Afterward, my dermatologist told me I could have picked up the virus from something as simple as having an open cut on my hand and touching a cart at the grocery store with a virus on it. Within only 3 days, my skin erupted as a result of exposure, and I was completely immobilized with lesions covering nearly my entire body, like you see here. Herpeticum attacks the nerve endings like shingles, and it was singularly the most painful thing I've ever experienced in my life. I was hospitalized and given round-the-clock IVs of antivirals and antibiotics because the doctors did not know what they were treating. My arms and my hands were so swollen I had to have IVs placed in my toes. It caused me to be bedridden again for a month. I looked like someone from the TV show The Walking Dead. I had black scabs all over my body. I wouldn't let my kids see me for another 3 weeks until I started looking a little bit more like myself. After that, my skin continued to recover from the damage done from steroids, and finally at around 5 years, I no longer needed a bath every morning just to calm the burning in my skin. So at 6 years off steroids, I still had a lot of chronic inflammation in my upper body with flaring off and on, especially with facial involvement like you see here. I began using traditional Chinese medicine herbs to treat my skin, and after about a period of 8 months, as you can see in the photos, I saw marked improvement, but had to stop TCM treatment due to the cost, which was around $600 out of pocket a month. So I have continued to heal, and I'm now nearly 9 years off of steroid medications. My skin is still sensitive, but has more integrity than I can remember even as a child. I'm extremely grateful to have my health back, and I'm very passionate about raising awareness to the impact of skin disease and in advocating for the appropriate medical care and treatment of all patients. Thanks again so much for having me.
Thank you. This is such an empowering story and a call to action. Thank you very, very much, Kelly. I want to remind those that are attending that you can submit questions in the Q&A box, and also you can send them through the chat function to the panelists. Now I'd like to introduce Leslie Stein-Lloyd to discuss the policy implications surrounding autoimmune and immune-mediated skin diseases, particularly addressing barriers to access and healthcare implementation. Welcome, Leslie.
Thanks, Irene. You can go to the next slide. So what a story from Kelly, and so grateful that you shared it with all of us. It really underscores the importance that women and physicians work together to identify the best care options for them and their family members. Shared decision-making is a really important component of caring for patients with autoimmune and immune-mediated skin diseases. It seems obvious, but the choice of therapy should be between a physician and the patient, where they together can consider all the factors, efficacy and safety of all the treatment options, the comorbidities that may exist, and the support system that a patient has, that they can all be taken into account. It can be fully vetted and discussed. It's also really important that physicians are able to have the entire compendium of pharmaceutical therapies available to them and the freedom to work with their patients to determine the appropriate course of treatment based on each patient's unique circumstances. Next slide. So we recognize that improving the healthcare system requires a simultaneous pursuit of 3 aims: high quality care, improving the public health, and reducing the cost of healthcare. And certainly we know that payers seek to do all 3. But often what we find is that attempts to rein in the high cost of healthcare results in payers implementing mechanisms that slow down or even prevent access for patients to get their needed medications. There are strategies like tiering drugs, restricted formularies, and step therapy or fail first mechanisms, ensure mandated drug switching and prior authorization that really they shouldn't be applied with a broad brush to new therapies, particularly where there's a strong unmet need. It's important for payers, same slide, thank you. It's important for payers to be able to make exceptions for patient characteristics and the current treatments that they're on. And it's important to note that if the provider, the physician believes that the recommended course of action that a plan is recommending could harm the patient, that the physician's perspective is adhered to. In general, it's important that patients have access to alternative treatments if the first line option isn't optimal or is contraindicated. Talking about formularies, and that's the list of drugs that an insurer has that they will cover. Those formularies must be developed based on scientifically valid evidence, and that the women and the family members that they care for really need options, especially if they can't utilize a drug or biologic due to a lack of response, side effects, or an allergy. In the event a restrictive formulary is put in place, there should be a clear and timely appeals process through which a physician can prescribe and procure medications that are not in the formulary without penalizing the women and the patients that they're caring for. Step therapy is a tool that's used by health plans to control spending on patients' medications. Step therapy can be an important tool to contain the cost of prescription drugs, but in some circumstances, it can have negative impact on patients, including delaying access to the most effective treatment, severe side effects, and irreversible disease progression. Currently, when a physician prescribes a particular drug treatment for a patient, the patient's insurance company may require them to try different medications and treatments before they can access the drug originally prescribed by the physician. This protocol is known as step therapy, or sometimes as fail first. These protocols may ignore women and her family members' unique circumstances and their medical history. That means that patients might have to use medications that previously failed to address their medical issue, or due to their unique medical conditions could have dangerous side effects. It's important that prior authorization and appeals processes not unduly burden physicians or the women and family members they care for when they're trying to access the best drug treatment for their condition. Prior authorization processes need to be standardized with a transparent and expedient decision process, because those delays can truly cause irreparable harm to patients who need specific care. Also, women and the family members that they care for with moderate to severe disease who are stable on the current therapy, they need to be able to remain on their current treatment without penalty. Forced switching of their therapy poses a significant risk to the patient flaring their disease, having a negative immune response, adverse effects, and secondary non-response. Switching therapy can also promote a loss of effectiveness of the prescribed medication if they have to resume the original medication later. To avoid these adverse effects of switching therapies and to ensure adherence to a prescribed treatment plan, in the event that a patient switches insurance, she should not be forced to repeat the step therapy process that she went through with the last insurance plan. Next slide. We do a lot of advocacy at the Academy to reform step therapy. We support federal legislation on step therapy, the Safe Step Act. The act would improve step therapy protocols and ensure that patients are able to safely and efficiently access the best treatment for them by amending ERISA to require group health plans to provide an exception for any medication step therapy protocol. In the early days of the COVID-19 pandemic, federal and some state policymakers, such as in California, waived or relaxed some step therapy requirements, recognizing that the importance of removing unneeded barriers to essential care in the middle of a public health emergency. In March of last year, the Medicare and Medicaid agency recommended that in the face of potential shortages, issuers in the individual and group insurance markets should waive prior authorization or step therapy for therapeutically equivalent formulary drug products. We are advocating for this approach to continue beyond the pandemic because it is good policy. In 2019, the Centers for Medicare and Medicaid Services, the agency that oversees the Medicare and Medicaid programs, allowed Medicare Advantage plans to use step therapy. We've been speaking with officials at the agency about the need to remove that mechanism from the program and stop it from being carried on any further. Next slide. In addition, we've been advocating for changes at the state level as it relates to step therapy. 30 states have enacted step therapy reform laws. The American Academy of Dermatology Association is a member of the State Access to Innovative Medicines Coalition. This coalition includes patient groups, physician organizations, and industry. We also call it the same coalition. And so this coalition has drafted step therapy model legislation, which is modeled after Connecticut law. And this legislation improves the step therapy process. It does not prohibit it, but it does require an insurer to put in place a process for requesting a step therapy override that's transparent and available to the provider and patient. It allows for automatic medical exceptions to step therapy, meaning if a physician says it's a bad idea, that they are listened to. And it ensures step therapy programs are based on clinical guidelines developed by independent experts, such as guidelines that the American Academy of Dermatology or other medical specialties and patient groups have developed. Next slide. The American Academy of Dermatology also supports legislation prohibiting health plans from making negative mid-year formulary changes. This is often called non-medical switching, but truthfully, we like the term of art, payer-mandated drug substitution, because it really describes the altering of benefit coverage to force a patient to change their medication for reasons other than what they and their physician deem to be best for them or their family members. When a patient's access to efficacious medications lost through payer-mandated drug substitution, the ability to manage the disease is impacted, and the patient can incur recurring symptoms and side effects. We also have seen that evidence that the more a patient switches from one biologic to another, the less effective later treatments can be, and the overall costs to the healthcare system could actually increase through increased visits to emergency departments, increased hospitalizations, additional office visits, and additional lab tests. But we recognize that there's a business need that's driving payers to make formulary changes, but it's paramount that the women and the family members that they care for have the ability to stay on their current treatments if it's efficacious without significant patient cost and burden. If they are stable on their medication, they should be allowed to keep using it. We do not support financial incentive programs that prioritize payer business interests over the quality and safety of patient care, such as financial incentives for patients who are stable on their medication to switch to another medication solely on the basis of cost savings to the payer. Additionally, we urge transparency in the entire pharmaceutical benefit manager or PBM operational structure. There are about 35 states that have enacted laws prohibiting the use of gag clauses in contracts, and we've supported that effort. So gag orders are provisions in contracts between a PBM and a pharmacy that prohibits pharmacists from informing patients about less costly options or prescription drug alternatives. Federal legislation, which the American Academy of Dermatology Association supported, was enacted into law in 2018 that prohibit the gag clause, prohibiting this restriction for drugs covered under ERISA, Medicare Advantage, and Medicare Part D. We've also supported legislation requiring licensure of PBMs and a framework for transparency in their operations, including at the state level in Minnesota and Montana. Next slide. Great. And then I just want to talk about some other opportunities to ensure access. So over the past 5 or so years, the Food and Drug Administration, the FDA, has demonstrated support for ensuring that new therapeutic agents meet patients' unmet needs. They've done this by conducting patient-focused drug development workshops for alopecia, areata, and psoriasis, and they issued reports called Voice of the Patient reports, really identifying the needs and the concerns that patients have with their current treatment options. Along the same vein, the Atopic Dermatitis patient advocates put together a meeting with the FDA to talk about their unmet needs as well. So the FDA is highly aware of the needs of patients with autoimmune diseases, and they have really prioritized advancing medicine that's geared towards meeting those needs. FDA approval of new drugs and indications is especially important given its effect on insurance coverage and ultimately access for patients with autoimmune skin diseases. So here, where the FDA has already put resources into identifying the unmet needs of patients with autoimmune skin disease, expedient approval of new therapeutic agents would be consistent. A primary driver of pharmaceutical costs is a reduced level of competition for a variety of drugs and biologics. So to that end, we support efforts to provide the FDA resources to expedite the review process and get additional drugs and biologics to the market. Recently, the Medicare program had proposed automatic coverage for 4 years to Medicare beneficiaries for breakthrough medical devices. The concept is not the concept is great. The implementation that was suggested was not so fantastic, but the concept is really sound. It's something to think about for drugs and biologics, particularly for autoimmune skin diseases. There's no reason that our Food and Drug Administration and our Medicare agency shouldn't be working together to streamline access. Furthermore, insurers and Medicaid programs need to be ready to expedite their review process to ensure that patients have access to newly approved indications and new drugs and biologics, particularly for diseases that have so few therapeutic options. And I just want to underscore the fact that these 3 autoimmune diseases have no FDA-approved cure. So there's a growing pipeline for medication for autoimmune skin diseases, which is super great. And to meet that need, the AADA has developed a panel of pre-vetted expert dermatologists who are ready to work with insurers, pharmacy, and therapeutics committees. It's important that dermatologists and the patients that they care for weigh into the review of new medications, and that dermatologists are able to weigh in for the consideration of new medications in a formulary. Dermatologists understand the unmet needs of patients with autoimmune skin diseases, and we have selected this group, really hand-selected them for their understanding of dermatology, their ability to weigh the costs and access issues that carriers have to weigh, as well as the various economic factors. And we remain ready to provide them to any insurer that is interested in tapping into this resource group. And with that, I will turn it back to you, Irene.
Thank you. Thank you so much for sharing. This has really set a good stage for the Q&A portion of this forum. Again, I invite attendees to use the Q&A box to ask your questions. We'll try to address as many individual questions and common themes as we can during this portion, but we may not get to them all. And so at this time, I'll ask Kelly, Arash, and Leslie, you can turn on your videos and we will pin you all up for this portion. Great. We can start off with, let's see, maybe Dr. Mostagimi, can you start us off? Someone has asked, why do atopic disorders worsen right before or during the menstrual cycle, and the impact of the cycle on these particular issues?
That's a fantastic question. Thank you, Irene, and thank you to the person who asked that question. I don't know the answer actually to that question, and I don't think it's actually fully understood why that occurs or the extent to which it occurs, because it's not necessarily the uniform experience of menstruating women with atopic dermatitis. There's, as one can imagine that, during the times around a woman's menstrual cycle, there's lots of fluid movements and shifts. So mechanically, there's a lot of differences there. In addition to that, there's we don't truly understand completely the impact of hormones on atopic dermatitis, which some have argued both directions. So a lot of kids will grow out of atopic dermatitis around puberty, while for other people, it's the time of their lives where atopic dermatitis begins. So I will use that mostly to highlight the fact that my last points is that these are the questions we should be asking, these are the things we should be investigating. And my hope is that if we understand that, it may lead to improvements in treatments and understanding of the science, not just for women, but for men as well. The more we know, the better we'll be able to treat these conditions.
Okay, there we go. Thank you. This is a combination question, I guess, for that you guys each might be able to weigh in on. So given the, complex and systemic nature of autoimmune and immune-mediated skin conditions, multiple healthcare specialties might be involved in patient care. And so how can providers or patients ensure that this optimal care is provided? Like what strategies or how have you done either in the clinic, Kelly, maybe in as a patient, how have you navigated being able to coordinate all of that care?
Are you asking me
Yes,
specifically?
and I guess you can start and then maybe Arash can follow up on his end.
Well, I think it's important for patients to realize that they really are their own health advocate at the end of the day, and patients should be empowered to really seek the kind of care that they deserve. And so sometimes you need to shop around a little bit for a doctor, but one that you can really have that shared decision making, like Leslie was pointing out, that's so important, the doctor-patient relationship, so that you're working as a team together.
Yeah, I agree with Kelly. I think there's two parts. There's certainly that shared decision making and a doctor who listens to you and understands where you're coming from and tries to connect you with treatments that not just work, but work in your life, which is often there's two different things, right? Two people with the exact same level of disease may warrant very different treatments based on who they are and how they live. But beyond that, I think, the more we understand about these diseases, particularly in atopic dermatitis and even more particularly in psoriasis, we understand that patients that have this level of inflammation often have other parts of their bodies involved. So today we spoke about psoriasis and psoriatic arthritis. Psoriasis is a disease of the skin treated by dermatologists. Psoriatic arthritis is often evaluated by rheumatologists. So there are some settings in which you have joint clinics. Some academic centers will have a rheumatologist and a dermatologist see a patient together and coordinate that way. In other places where you don't have access to that, I think you'll have to do exactly what Kelly was suggesting, shop around and find somebody who listens to you and has the appropriate connections with other physicians to create that dialogue and determine best steps when some of the parts of your care may fall outside of their direct expertise.
And Leslie, what about you? Do you have any weigh in on how policy can help to support that, or if they're that's something that people should be aware of when navigating on the payer side or the insurance side?
Sure. So one of the things that we do at the American Academy of Dermatology is we develop clinical guidelines. And it's really important that when we develop clinical guidelines, these are non-binding, but they're basically taking a panel of expert dermatologists and identifying based on the evidence that's out there and what they see, what is the best way to care for patients. We have really extensive guidelines right now for atopic dermatitis and psoriasis. But what I wanted to mention is that we don't just look within dermatology. So our psoriasis guidelines were developed in conjunction with the National Psoriasis Foundation, which is a patient advocacy group. So the patient voice was really captured in there. And then the other thing that we do always when we develop our clinical guidelines is that we put them out into the public domain for others to weigh in on. So it's really important that we have rheumatologists or other physicians who are treating different components of a patient's disease are weighing in on the guidelines that we're developing to make sure that the care, that the standards for care cross the disciplines as needed.
That's really good. I know there's always there's always a desire for treatments and innovation, and there's a new Janus kinase inhibitor medication that was recently approved for treating atopic derm. And I believe it's also in the works for some of the others. What does this new class of drugs mean for treating these autoimmune conditions?
Sure, I can take that. I think the Janus kinase inhibitors are a new class of medications that target a pathway called the JAK-STAT pathway. And the JAK-STAT pathway is a sort of a fundamental pathway in human immunology that is reflected on a bunch of different cells throughout your body. But what we've identified is that it plays a cardinal role of propagating the inflammation that one sees in all three diseases mentioned today: psoriasis, psoriatic arthritis, atopic dermatitis, and alopecia areata, in addition to other conditions which we didn't talk about today. So the advantages of this pathway are, first, that the medications to treat it are oral medications, which is different than a lot of the injectable medications that we identify with some of the other biologic treatments that we do. The second advantage is that is a plus and a minus, that because these pathways are somewhat ubiquitous and in different parts of the body, they're quite anti-inflammatory, meaning that they work quite well and are quite effective across a lot of conditions. The negative part of that is that, unlike some of the highly targeted therapies you might develop with specific biologic injectable therapeutics, these are broader in terms of their anti-inflammatory action. So the long-term data with regards to their safety and benefits and infectious risk, cancer risk, have not yet been established. In the short term, particularly in dermatology patients, they seem to be well tolerated, particularly from a laboratory monitoring standpoint. There has been some suggestion, and there probably will be a black box warning on all these medications, that clotting risk may be increased in patients, although we haven't quite understood how to apply that specifically with the dermatology population. So to summarize, Irene, this is why I get to be so professorial. To summarize, I think it's a promising new class of agents. It's exciting because it gives us new opportunities to treat medications, and in a non-steroidal way. So getting back to Kelly's story, in a way that doesn't require steroid treatment. But like anything else, we have a lot to learn about it.
Yeah. I know it's always, it brings in, there's a bit of, it's great to see the treatments progressing and new opportunities being out there, and just keeping an eye out for, if it's relevant and they should talk to, and again, always talk to your, healthcare provider about whether or not it's appropriate for you.
I think what Kelly had mentioned about shared decision-making with the physician, this is the ideal time for that, because depending on your personal experience and how much your disease is impacting you and your personal risk tolerance level, and also your other medical conditions outside of your autoimmune condition, the risks and benefits of you specifically taking that drug may be very reasonable, or maybe something that you want to avoid. So at the core of all this, I think, is having a strong relationship longitudinally with the physician or physicians that you trust to help you keep up to date with things and work through the newest that we have to offer.
And so to that end, I know there's a bit of as you read about various treatments and things, or just addressing these skin conditions, there sometimes is a narrative or a conversation that it's cosmetic, and that it's elective, and that it's not medically necessary. For example, like alopecia patients being able to get wigs or cranial prosthesis, or and you touched on that earlier, Arash, and then even for some of the concerns or issues like Kelly, you mentioned with eczema, to clear, it's not a big deal, or you'll grow out of it when you're younger. I want us to talk a bit, or if you guys can weigh in on, why is it important to address that narrative so that we can expand coverage, or how have you assisted your patients, or Kelly, how have you helped to work with other patients? So from your perspective, I would like all to weigh in, because I think it does apply everywhere, what it looks like. And it looks like, Arash, you had something to say first. We can start with you.
I actually think Kelly and Leslie's perspectives are much more critical here. I'd love to hear what they say.
Okay.
Sure, I'm happy to start. So, I want to underscore the fact that these autoimmune diseases are serious diseases. And, I work for the American Academy of Dermatology. And one of the things that we have invested in heavily is something that we call the Burden of Skin Disease Report. And we released this report in 2016 in a series of journal articles. But basically what we did was we took each disease state and we conducted as much research as we could, claims research and other data sources, to really hone into what does it cost society to care for patients with diseases like alopecia areata, psoriasis, psoriatic arthritis, and atopic dermatitis. And those costs are significant. And we're a little bit limited in what we could look at because we're only as good as the data is. So I know that in previous conversations, Kelly's talked about, all of the different out-of-pocket costs that she has had to contribute to caring for her disease. And we really rely on claims data, truthfully, to demonstrate that burden. But the more that we can raise awareness and gather information about what the true burden of a disease is, the more that we can then take that data and bring it to key decision makers at payers and in the government to convey to them the very important aspect and the impact of covering care for these diseases, to avoid absenteeism, to help have a robust workforce of people who suffer from diseases that keep them, from having front-facing physicians or keep them from wanting to have the confidence to move forward because they're up at night, struggling with their itch and they can't sleep. So all of those burdens, being able to capture that in our research is really critical. Maybe Kelly, you want to talk a little bit about some of that too?
Sure. Yeah. I think for a really, really long time, I know the atopic dermatitis community anyway has kind of been this sleeping giant, I like to think of them as. And I know when I was growing up and thinking, this disease is so common and it's so prevalent. Why don't we know more about it? Why doesn't anyone really know how to treat me? I just was really frustrated that all we had were topical steroids. It wasn't really getting down to what was really going on. And I think a lot of us just became, marginalized, or we felt marginalized. So we just kind of stepped back and thought, well, there's nothing I can do. This is just my fate. I'm going to have to accept it. And so many people just dealt with their disease in isolation. And it's funny that, I spoke at the patient-focused drug development meeting and my parents were watching, and my dad told me afterwards, I had no idea that you were so impacted. Because even as a child, I didn't want to burden people. I didn't want to always be talking about the way that I felt and, how miserable I was. You just kind of get to the point where you just be quiet and you try to live in spite of what's happening in your body. This is so common for people with these kind of diseases. It is so much more than skin deep, right? Just like what we're talking about right now. The isolation that you feel, the social impact when you have a skin disease, many times people associate that with infectious disease. And so there's just this aversion to you. And I've even had times where, I did some transaction at the bank with someone, I shook their hand and they immediately pull out the hand sanitizer. And it's just that kind of stuff where I understand, you don't know me, you don't know what I'm dealing with, but that kind of a reaction to a person is really painful. It hurts. And there's a mental health aspect to this that not a lot of people talk about, where again, isolation is a big part of that, but just feeling like you're less than, or there's something wrong with you, on top of feeling like you have to kind of hide what's going on with the itching, with the lack of sleep. And, we talked about caregivers. There have been studies that have come out recently showing that caregiver burden with some of these diseases are almost as significant as the patient themselves, because the mothers had to stay up with their kids all night. They have to be, taking care of them and putting them in baths and wrapping them up and all these messy treatments. And it really affects what you can do on vacation, where you can go as a family. It just impacts so many areas of your life. And so I think it's really important as these new treatments, I feel like, are coming up, this hope is rising back up in patients again, and they're starting to get engaged and they're starting to speak up and share their experiences. And that's really powerful, because you have one person speak and then someone else feel like, okay, I can share how this is impacting me too. And I think we're finally getting a better understanding of what these people are really dealing with. And we talked with atopic dermatitis, it's 16 million, but eczema is 31 million people in the US right now. And up to 20% of our kids are being diagnosed. This is an important issue to address. So I'm really glad that we're here together. We're in this forum and we're talking all around the table of how can we really address this and help patients in the long run.
I'll just add one last point that I think as an extension of that, both Leslie and Kelly were speaking about the general community's perception of these diseases. I think that one thing we actually have to convince some patients is that their disease actually matters themselves. They themselves have a hesitance and see their own diseases, despite the terrible condition and impact it may have had on their lives, as being cosmetic. And it's a source of almost reluctance or shame in terms of accessing or spending resources on accessing care. So part of what Kelly was suggesting about people's perception of it, it seeps into individuals with the disease themselves amazingly. And I wouldn't be surprised, Kelly, if part of the reason, I mean, you're downplaying it as a kid, right, was part of that too. It's just like, this is something I have to deal with. And people get used to unbelievable burdens of disease year after year after year. If this is your life, this is your life. I've had patients that had such terrible eczema that they never knew what it was like to not be itchy all the time until they really got their disease under control. So it's a great point. It's a complicated issue, and one that I think we have to continue to advocate and develop.
I wanted to get your advice for primary care, because, you know, not everyone will necessarily go to a dermatologist when it's onset or they feel a little rash. They're going in either for their annual physical, or they're just seeing their PCP or the pediatrician. So they're not dermatologists, they're not rheumatologists, they're not specialized in this. What advice would you give to a primary care provider that is approached with this, or how to handle it, or, you know, speed, or what to do to make sure that it's not dismissed? I mean, you can't look into everything, but what should they be looking out for?
Yeah, I think primary care doctors, first, I deeply respect primary care doctors and are appreciative of everything that they do. The majority of dermatology disease in this nation is treated by primary care doctors, and there would never be enough dermatologists to manage all those conditions. You know, so we provide valuable expertise, but in conjunction with our first line colleagues. I think the best thing to do as a primary care provider is honestly to listen, take a history, talk, connect with your patients. And then if you, there are basic and rudimentary things that can be done that will treat the vast majority of your patients. If you're not successful or your patient is not doing well, I think at that point, making sure to refer that patient on or refer them to dermatology to get them specialty care, and erring on the side of referring more people rather than being the gatekeeper to reduce those referrals is the way to go. You know, the primary care doctors have a deep advantage in the fact that they know their patients really well. They often have lifelong connections with them, and sometimes even with their family members. And I think that's a point of strength to start on. If you know your patients, know what's impacting them, then you can try, you know, first line treatments, but then have a low threshold for escalating care when necessary.
If I could also just add in, someone had asked in the Q&A earlier about telemedicine. You know, the opportunity to use telemedicine to increase access to care is really a wonderful opportunity, particularly for patients who don't have access to dermatologists in rural and underserved communities. There's the telemedicine project called Project ECHO that connects primary care physicians to dermatologists, where they can bring concerning cases to them and get an opinion. So it's physician to physician. And, you know, I think the promise of dermatology is of telemedicine is to increase access really for folks who need specialized care and need care where they're not getting it. So just wanted to raise those issues as well.
Thanks. That would be great. I'm gonna look that up and see if we can. I'm gonna do a shout out to Carolyn, if you can see if we can find that and drop it in the chat before we close out. Just a link to that Project ECHO. Thank you for that nugget. And there's also a question that came up about alternative therapies that a lot of women will turn to. So vitamins, mineral supplementations, hormone replacements, in conjunction with or instead of conventional therapies when there's not something that's that seems to be working. And so I know, Kelly, you mentioned that. Maybe you can touch on that, and even on the medical side, what is a clinical thought to that, or risk, harm, benefit? So Kelly, I guess you can start.
Well, I think at the end of the day, like I mentioned before, we are our own health advocates. We do need to take our health seriously and be responsible for that. And so if that means conventional medicine, if that means looking into a naturopathic doctor, or otherwise, I think what's most important is that, again, we come back to that shared decision making, and you find a doctor who you feel you really can trust and work with, and talk to them about some of these different options. I know there's more movement toward integrative care. I know of a group called Learn Skin, a group of dermatologists and naturopaths and homeopaths, and they're coming together to share knowledge, because patients want to know what their options are, right? We want to know, so that we can make those choices. And I think first and foremost, you need to have a physician who you really connect with and who can help monitor your care. I just wanted to speak back to when we were talking about the GPs, that it's important that I think they know when to refer a patient. I think just going off of what we were talking about before is that if a patient isn't controlling their disease, like in my case, I needed higher and higher potencies of topical steroids over time to manage it, and it was just spreading. Well, that's a great indicator that it's not well controlled, and I should have been, referred to someone else at that time. I think when GPs know when to refer those patients, that's really important.
We've done several studies, Irene, looking at use of complementary and alternative medications in alopecia areata. And I think where people get hung up is that absence of data doesn't necessarily mean that things don't work. And those are not very well studied and not very well characterized, a lot of those treatments. But they may not only provide direct treatment for some of these diseases, but there's a lot more to them, that how you feel, your mental health, your state of relaxation, other conditions, other treatments associated, other ways in which one can be better, right? And feel better. So I agree with Kelly. I think that finding a physician that wants to work with you, I would be honest, I wouldn't hide these things from your physician, just have a conversation. If your physician is not open to these ideas, then you may need to find somebody who is. But ultimately, my sense is that as we have better treatments that are developed with more rigorous data, hopefully the need for alternative therapeutics will reduce as we have better just first line, second line, third line therapeutics that we completely understand. So it's a balance. You want to protect patients from doing things that might be harmful. If they're not physically harmful, certainly a lot of times financially harmful, because they can be very expensive, right, to do those things. But at the same time, respect that there's different approaches and opinions when it comes to care. And that integration, as Kelly mentioned, is often a reasonable path forward.
And before, I have one last question for you guys before we have closing statements. It came up a bit prior about women as caregivers, and, women suffer from these diseases, or, they're affected, but then also, as we mentioned, children are increasingly being diagnosed with some of the, particularly atopic derm and some of these other conditions. And so there is a family history component to it that can contribute to a bit of guilt from parents as far as, was I the one who caused it? Especially if the mother also has the condition. It's like, well, it's because of me, or even just having to deal with a child who's not able to really advocate for themselves and what that looks like. And so are there thoughts that you guys want to share as far as, in your experience, what that really looks like for people to understand the impact that autoimmune conditions have on caregivers?
I know I've spoken with a lot of mothers who carry a lot of guilt, even guilt about the way that they feel about the situation, and they feel bad for wanting a life. Many of them have had to go to part-time or quit their job entirely to be able to take care of their children. And their lives are limited, just like, as we mentioned, the patient is. So I think in these cases, just as with patients, it's so important to get mental health support. I know I've talked with a lot of mothers who found a lot of benefit and help with that, and realizing that it's not their fault, they didn't do this to their child. even with treatment, because we've seen kids going through what I did with the topical steroid withdrawal, and moms feel guilty. I did this to my child. I should have known better. But moms are trying to do the best they can for their kids. And so they need support just like the patient needs to support. And yeah, I just want to give a shout out to all the moms out there, because I know my mom was there for me. And when I was bedridden, she was there by my side taking care of me. I mean, there's something so powerful in that relationship. So.
Yeah, in the end, Irene, I think it speaks to a fundamental need for acknowledgement of just the profound humanity of the situation.
Yes.
Being a parent is always associated with sacrifice and wishing, the world for your child, right? And to get back to your first point about the guilt of potentially passing something on, we always talk about this with my own children. My own daughter has alopecia universalis, where as a parent, you pass on a lot of good things, and that's bundled with some things you may not want to pass on, and that's just part of life, part of genetics, and part of how it is, right? So that's just the nature of things. And if we focus just on the negative aspects or things we wish we hadn't given to our children, we can turn a blind eye to all the love and support and other attributes that we are beneficial. It's a bundled deal, as we like to say. I think ultimately, if we really acknowledge that people are trying to do the best, that patients are trying to do the best, parents are trying to do the best, physicians are trying to do the best, in the limits of the time and energy and resources that they have, and really identify that the majority of things that we may look back to, a lot of the treatments that we do now, and be like, can you imagine we ever did that, right? Or can we imagine that was something we ever considered doing? That doesn't mean that those are wrong things to do now. It's just progress, and as life moves on and information moves on, we can do better. I mean, I think that's why the work of people such as Leslie, who are focused on expanding the options and treatments and therapeutics and access, and improving the really advocating for patients to have the best and progressing. That's why it all goes hand in hand with everything that is already done to make sure we provide the best experience for patients and their caregivers.
Thank you. And so as we are wrapping up, I do have one last question for each of you. We have patients, researchers, clinicians, policy professionals, industry professionals working that are all watching this. What is one takeaway that each of you would recommend to viewers to help them support and improve care for women, patients, and caregivers of autoimmune skin conditions? And I guess we can start Leslie, Arash, and then Kelly.
Sure. So I think my takeaway is to be open and to listen. Now, it's so important for physicians to listen to their patients, and for key decision makers, members of Congress, state legislators, carrier medical directors, to listen to the physicians and the patients that come to them, because they know their diseases, they know the impact and their quality, and they're not coming asking for a handout. We all understand that we're in a healthcare system where we're trying to balance very, very high costs. But the cost to patients for who have autoimmune skin diseases and they don't have treatment options that are improving their care has a tremendous toll on society. So I guess what my takeaway is to listen, include physician and patient advocates in decision-making, include them on your P&T panels, and and to the patients, it's hard to move over your story. It's hard to move beyond the guilt that we all feel it as parents for all the things that our children have that we wish that they didn't. But to take that guilt and turn it into action and be an advocate like Kelly is incredibly profound. So I'll pass it on.
I'd like to thank everybody for joining us today and spending your afternoon listening to these critical issues. My take-home point would really be that I want to focus on where we need to be mentally as a group. I think we should be deeply appreciative, because we're in a very different time than even 3, 5, certainly 10 years ago, in the amount of knowledge and information and science and medical therapeutics that are coming out. But while we can be appreciative of how far we've come and where we are, I think we must be careful not to be satisfied with it, because there are such large gaps and so many areas left to fill. And there are so many things that, although it looks like, oh, we have 10 therapeutics for psoriasis, isn't this problem solved? No, it's not. It's not solved until everybody has access, everybody who needs these treatments has equitable access to a drug that they can afford, that's safe, that works within their lives. And if that's our goal, where we can appreciate where we've come, we can also see how much further we have to go.
And I would just say, every single one of us has a piece of the puzzle that's going to help fix this problem. Patients, doctors, policymakers, decision makers, industry, all of us have a part to play. And I think once we realize what that means and the purpose that we have in that, it's extremely powerful. And I know patients, they need to be empowered, like Leslie said, to share their story and to get engaged. And it's very hard to do that. I mean, the last thing you want people to see about you is something ugly or something that you're ashamed of. It's very hard to cross that bridge, but it's needed. With physicians, we need them to listen to patients. Patients many times are experts of their disease because they live with it 24/7. There's a lot that they can bring to the table as far as progress and discovery. Policymakers and decision makers are in a position of authority where you can make tremendous change if you'll listen to everyone at the table and really consider all parts to play. In industry too, with research, it's just, I get excited about it because I know that once we do come together in forums like this, we can really affect a lot of change. So we all have a piece of the puzzle. What is yours?
Yes. Thank you so much for all of you, for your comments, for sharing today. There was one comment that I do want to address, because someone asked about lupus, discoid lupus, as part of the autoimmune skin program. And so we were focusing on atopic dermatitis, alopecia areata, and psoriatic arthritis for this particular program. But we are definitely, as we learn more and we look at where we can affect change for women's health, we are definitely looking at other areas in the autoimmune space that would be relevant and that we can work with. And so thank you again for joining us for today's event. Thank you to our amazing panelists for your time and your insight, and to Eli Lilly for their support of this public forum and SWHR's autoimmune skin programs. We'd also like to thank everyone who contributed to the development of the SWHR autoimmune skin resources. And to all those who are watching, we invite you to connect with us on social media and visit our website, www.swhr.org, to download our resources and fact sheets and sign up for our newsletter, #SWHR Talks Skin. Lastly, we will send out an email with a recording of today's webinar and to all the registrants, so please be on the lookout for that. Thank you again for joining us.